We are waiting for another very big legend, Dr. Rajesh Rajput. Again, I would not take a lot of time to introduce him. He'll be talking on positioning of TIR. TIR is the buzzword today in treatment of diabetes. He is a person who has more than 150 research publications and a lot of fellowships. If I name few of them, FRCS, endocrine, pregnancy, women health, and diabetes. He's an inspiring diabetologist and endocrinologist award from Economic Times in 2020 and a reviewer of JIACM 2002 onwards. So over to you, sir.
Thank you, Dr. Binawat, for invitation and inviting me for this year's Knowledge Forum conference. Although I wish to come in person and deliver and interact all of you, but COVID has forced us to this webinar. Again, I'd like to thank entire organizing committee for inviting me. I am going to discuss a very important topic which largely our practitioner colleagues are not aware of, time in range in diabetes, and then we will discuss briefly the role of newer basal insulins. So agenda which I am going to discuss, the concept of time in range and its clinical implications, and what are role of newer basal insulin for time in range. So what is concept of time in range? Now if we see traditionally, HbA1c we are utilizing and it has been deeply ingrained in our minds. HbA1c reflect plasma glucose over previous 3 months, and presently it is utilized both for diagnosis, follow-up as well as management of diabetes. However, there are certain inherent limitations of HbA1c. These are that it does not capture hypoglycemia. Number two, HbA1c does not capture glycemic variability. What do we mean by glycemic variability? If you see, these are profile of 3 patients who have same HbA1c of 7%. And HbA1c of 7% means an average blood glucose of 154 milligrams per deciliter. So there, as you see in this slide, there are 3 phases of 7% HbA1c. If you see the first cartoon, there are huge fluctuations and the range of glucose is 70 to 180. And the patient is moving from hyper to hypos. And if you see the green, it is time in range. This is only 40%. Patient has 20% times hypoglycemia and 40% of the time in hyperglycemic range. In second graph, if you see, 70% are in time in range, 25% hyperglycemic episodes, and 5% below range, that is time below range. While in third graph with an HbA1c, where there is almost a flat time in range curve, most of the time glucose values are in range, 100% of the values are in the range. So if you see, if we see only 7% HbA1c, we are assured that patient is in target. But in contrast, there is gross difference between these 3 patients, and the patient number 1 and the patient number 2, as we are going to discuss, are at much higher risk of future macrovascular complication, in contrast to patient 3, where patient is in range largely. So we will discuss what is this and how to measure time in range. We can take help of CGM, that is continuous glucose monitoring system. With conventional SMBG, it is difficult to measure time in range, so we need CGM monitoring. So what is definition of time in range? It refers to time spent by an individual into target glucose range. And what are the target glucose range? It is 70 to 180 milligrams per deciliter. Percentage of time spent below the range, that is less than 7, is known as time below range. And the percentage of time spent above, that is 180, is known as time above the range. Now, TIR is used as an appropriate endpoint in clinical research. Also, now it is used as a measure of better glycemic control in patients of diabetes. And now, lots of evidence have been generated in recent past, which suggests that TIR, that is time in range, is inversely related to development of micro and macrovascular complications in patients of diabetes. Now, this is international consensus statement for time in range utilizing CGM. What are that recommendations? That for type 1 and type 2 diabetic patient, Patient should spend more than 70% of the time with glucose values in 70 to 80 milligram per deciliter, that is target range. And if we see the other values, less than 25% of the time values should be more than 180 milligram per deciliter, and less than more percent it should be time below range, that is glucose value less than 70. If we see similar to HbA1c, where now we have targeted HbA1c for different population, in elderly individuals who have long-standing diabetes, or in type 1 and type 2 who are at very high risk of future cardiovascular event, their TIR is more than 50%, while time below range is less than 1%. In pregnancy, again, our target for TIR is more than 70%, time below range less than 4%. It is similar to type 1 and type 2. When we see GDN, pregnancy and type 2, then if we see time in range, it is significantly different in contrast to other patients. So again, there is individualized time in range targets, and this is from the international consensus statement published in Diabetes Care in 2019. What is important to understand is that for each 5% increase in time in range, it is associated with clinically significant benefit for both type 1 and type 2. Now, some of you must be wondering from where this figure of 70% comes. Now, if you see, there is a good correlation between time in range and HbA1c. So, if an individual spent more than 70% of the time in range, and if we translate into HbA1c, most of the time it will be 6.7 or less than 1. Also, for every 10% change in time in range, there is approximately 0.8% change in HbA1c. So if it increases from 70 to 80, your HbA1c is improved from 6.7 to 5.9. On the other hand, if time in range is decreased from 70 to 60, your HbA1c is proportionately changed by around 0.8%. Now, if we see the relationship between time in range and microvascular complication, again, this is a recent publication in Diabetes Care 2019, where it has been shown that for each 10% decrement in time in range, retinopathy increases by 64% and microalbuminuria changes by 40%, and this is highly statistical significant. So as we move from 70 to 60% or 60 to 50%, there is increased chances of progression of retinopathy and nephropathy. If we see the relationship between carotid intima media thickness, a marker for macrovascular disease, again the studies have shown that for each 10% increase in time in range, that is if you have moved from 70 to 80, better glycemic control, there is around 6.4% lower risk of abnormal carotid intima media thickness. Not only that, very recently in 2020, in American Diabetes Association virtual meeting, relationship between time in range and MACE, that is major adverse cardiovascular event, has been shown. If you are spending your time, hello? If you spend more than 70% of your time in range, then the risk of MACE reduced by 27%. I request those listening the webinar, please mute themselves. Your voice is coming to me. Now, if we see the 10-year cumulative incidence of developing diabetes-related complication, once you have asked the patient to improve time in range, there is significant betterment in terms of reduction in myocardial infarction, progression of end-stage renal disease, progression of retinopathy, and the risk of amputations. So friends, in very brief and in crisp, I have told you there is a new concept that we should start thinking beyond HbA1c. Time in range is a new concept where most of the time patient should have more than 70% of the time spent in the range, which is 70 to 180 milligram per deciliter. If patient is doing that, then probably there will be less hypos and less hypers. There will be less risk of progression of micro and macrovascular complication. Now let's understand the role of newer basal insulin on time in range. Now before we go to that, there are different type of basal insulins available. This is the classification which is made by me, that conventionally we have the first NPH, which is a basal insulin. Then comes the first generation basal insulin analog, which are glargine U100 and detamil. And now we have second generation basal insulin analog, which is degludec and glargine U300. What are the properties of an ideal basal insulin? Half-life of an ideal basal insulin should be more than 24 hours. It should be truly peakless with low trough to peak ratio, minimum or no day-to-day variability, because now we are talking of glycemic variability, and flexibility. Because of long half-life, it should give flexibility to the patient, should have minimum risk of hypoglycemia and weight gain. If we compare NPH with glargine and with detamil, as you see clearly with NPH, there is 68% day-to-day variability. This has been reduced in glargine to 48% and further reduced in detamil to 27%. But still, there is a room for improvement. And understanding this unmet need, there is second generation basal insulin analog, where degludec was the first one to come into the market. If we see mean half-life of degludec is almost double of glargine U300, and it has a flat time action profile when it has been tested in different doses in patients of type 1 diabetes. When you compare day-to-day variability and compare degludec with glargine U300 as well as glargine 100, as you see in this slide, degludec has a 4 times less glycemic variability as compared to glargine 100. Glargine 300, which is a technologically advancement over glargine U100, and it's a concentrated form of basal insulin with a longer half-life. Here, the glycemic variability is 2 times higher as compared to degludec. So definitely, degludec has shown a better profile in terms of reduction in glycemic variability, both in comparison to glargine 100 as well as glargine U300. Now, if we look for some of the evidences, these are evidences which has been generated in phase 3 and phase B clinical development program of degludec, that is begin development program and switch to clinical trials. And then we have a dedicated CV outcome study with degludec, that is devote study, and then real world data, which is EU treat type 2 diabetes study. As you see in this slide clearly, overall nocturnal as well as severe hypoglycemia, they are significantly less with degludec as compared to glargine U100. Now, this is a very recent study where degludec has been compared with glargine U300 in a trial which is known as conclude trial. In conclude trial, if you see the overall symptomatic hypoglycemias, numerically they are less in degludec arm, but they failed to reach statistical significance. However, when you look for nocturnal and severe hypoglycemia, they are significantly low in degludec arm as compared to glargine arm. Now, understanding that degludec has a flat profile and the low risk of hypoglycemia as compared to other basal insulin analog, now let's discuss the role of basal insulins about the concept of time in range. Now, again, this is a very recent study published and presented last year in European Society of Endocrinology meeting 2020 in September, where they have tried to study the effect of degludec on time in range. In this study, it has been shown that with degludec, there is significant advantage in terms of time in range over glargine U300. It is improved by 1.43%, which translates to about 20.6 minutes. Each 1% improvement is equivalent to 15 minutes better improvement. If we see the time below range, that is hypoglycemia, both level 1 as well as level 2 hypoglycemia are significantly reduced with degludec as compared to glargine U100. Now, another study presented last year where it has been shown that more patients achieved clinically significant differences in time in range when they were given degludec as compared to glargine. Around 40% of the patient achieved the target of 70% as compared to 28% of the patient with glargine U100. Now, if patient has been switched, if you're treating your patients of type 2 diabetes and they are not maintaining their glucose in range, and now they are shifted to degludec, in this study, they have shown that with the use of the degludec, your coefficient of variation of glucose, mean amplitude of glycemic excursion, all are significantly improved with addition of degludec as compared to other drugs. Now, this is a raw CGM graph of a patient where if you see the topmost graph, see the huge fluctuations in glucose parameter. Now, when the same patient is shifted to degludec, you can see and realize the differences in glycemic fluctuations. There are less hypos, there are less hypers, which means time below range and time above range, and patient is spending more time in the target glucose range. Same is shown in this study where it has been shown that in patients who are switched to degludec, there is a significant advantage as far as reduction in coefficient of variation and standard deviation of glycemic variability is concerned. Now, this is a trial in type 1 diabetes known as hypodec trial, where again glargine 100 is compared with degludec, and in this trial it has been shown that with insulin degludec, it has resulted in significant decrease in incidence of hypoglycemia or time below range. Lastly, friends, comparing degludec with glargine U300, where again time in range is compared, and again this is published in 2019 in Journal of Clinical Investigation, whereas you see clearly in this slide, numerically, more time is spent with degludec as far as time in range is concerned. Although in this study, statistical significant difference is not seen between glargine U300 and degludec. To summarize, time in range is a new concept where a closure view of person glycemic status, and it will help us in better glycemic control. It has been clearly shown that there is an association between time in range and micro and macrovascular complication. If you increase the time in range, there will be reduction in micro and macrovascular complication. International guidelines are now updated based on consensus CGMS data. All of us now should know about this international consensus guideline, which I have discussed with you in brief at the beginning of lecture. When we have seen degludec and compared with glargine U100 as well as with glargine U300, with degludec, there is an improved time in range, superiority confirmed. There is improved time in range, and there is reduction in time below range, that is hypoglycemia, both level 1 and level 2, and more patient clinically difference in time in range. Thank you very much. I have tried to give you a very simplified overview of time in range and the role of newer basal insulin in achieving this concept. Thank you very much.
Rightly said, sir. You have really made it so simple. Although time in range is a new concept and it takes some time before, but you have made it so easy that everybody has been able to understand what exactly is time in range. And yes, with your lecture, it can be really appreciated that time in range has become very important. But there's only one question, sir. CGMS
Yes.
not really available to everybody. And for a common man to have an AGP or CGMS is not so common. How other things? Is there an SMBG or
No,
replacement for CGMS?
SMBG cannot replace time in range. There are various companies which are now marketing different type of CGM equipments, and flash glucometer is one which is easily available nowadays in the country. But I totally agree with you. Till that time, physicians are made more aware about it and the cost associated with it. That is also important. So if patient is able to afford it, only then actually it is going to be translated into real world clinical practice. Otherwise, only at endocrinologist chambers or in institutes, these technologies are going to be utilized, and largely our diabetic patients which are seen by our general practitioner colleagues, they are probably not going to get benefit of this new technology, which is actually very beneficial over and above HbA1c. I totally buy your point.
Thank you, sir. Thank you very much. And I'm really so thankful to you. You have really spared very important time from your duties as such. And I'm really very grateful to you. Thank you very much, sir.
Thank you, Dr. Minawat. Just before I stop, just small comment. Next year, whenever you are organizing knowledge form conference, one suggestion, just organize a workshop on time and range, so that
Right.
our colleagues can attend that workshop, can understand this concept. Because I believe with all our colleagues, there are some type of patients who can afford and who can be benefited by this type of technological advancements. That's all. Thank you very much. Thank you for the invitation.
Right, again, sir. I will note it down, and next time you will see it will be done, sir. Thank you very much, sir. Thank you.
Thank you very much. Right.